So what is sepsis? Well, sepsis is a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. And the only proven method of reducing mortality is early recognition and early treatment. And it was with that in mind that the NCEC published the National Clinical Guideline number 6, Sepsis Management, in 2014. This guideline outlines the management of sepsis from presentation through to intensive care provision. Its implementation is being guided by the National Sepsis Programme. Although the guideline encompasses the full suite of care for the patient with sepsis, the programme has focused on the diagnosis of sepsis and the first-hour treatment, because much like Professor Guthrie mentioned to us earlier, this is about ownership. 70 to 80% of sepsis comes from the community. One of the biggest barriers to sepsis recognition and treatment has been the understanding that sepsis is an intensive care problem, or indeed that it's a hospital-acquired problem. It's not. Sepsis is primarily a community-acquired problem that comes in through the emergency department and then is cared in the acute hospital sector. A small proportion is patients who acquire hospital-acquired infections and subsequently deteriorate and develop sepsis. So in order to achieve the aims of early recognition, correct diagnosis, and early appropriate treatment, we need to focus on those frontline carers who meet the patient at the door in the emergency department and who are the ones who care for patients on the ward. So this programme is largely directed at the nursing staff and the non-consultant hospital staff who are the first responders in caring for these patients. Our process aims are to ensure that the patients are correctly diagnosed and that once diagnosed, that they receive the Sepsis 6 care bundle within 1 hour of that diagnosis. Now, this bundle is a very simple bundle. The difficulty is giving it to the right person at the right time. So there are big process issues. So what is the Sepsis 6? Well, we give patients oxygen, but only if they need it. So it's patient and person-centered. We give patients IV fluids, but only if they need it. So we need the technical skills to be able to assess, does a patient have a fluid deficit? And if so, how to correct that fluid deficit without doing any harm. So for that, to facilitate that purpose, we've developed a fluid resuscitation algorithm for non-critical care staff. And we need to give patients IV antimicrobial therapy. But within the growing awareness of the difficulties with antimicrobial resistance, we need to give the right antibiotic to the right person at the right time. So we recommend the start fast, start smart, then focus approach to antimicrobial guideline. So that means that the antimicrobial prescribed is targeted to the site of infection that's identified on history and examination, be it the respiratory tract, the genitourinary tract, the abdomen, etc. The source of the infection, is it community acquired, healthcare associated, or hospital acquired, and taking into consideration the patient's allergy status. There are 3 diagnostic interventions: blood and other cultures taken prior to antimicrobial administration, and then blood tests and other investigations. And as part of assessing the patient's fluid deficit, we need to assess their urinary output. And then patients who are demonstrated to have acute organ dysfunction consequent to the infection, or have hemodynamic or respiratory instability, need to be escalated to specialist care as required, that being usually critical care. But we also have to take into consideration source control, because patients with a collection, antimicrobials require a blood supply to deliver them to the source of the infection in order to kill the bugs. If there's no blood supply, the antimicrobials can't achieve their job. Our outcome aims are a mortality reduction of 20% over the 5-year programme. We're now 2 years into that programme. And we also wish to decrease by 10% critical care admission rates due to sepsis and hospital length of stay due to sepsis. And in turn, decrease the chronic sequelae that occur in patients who survive severe sepsis and septic shock. The national programme has taken a multimodal approach to achieve these aims. We have visited all of the acute hospitals in the country, meeting with hospital management teams and delivering sepsis education programmes, and this is useful in terms of raising awareness. We've approached the undergraduate, postgraduate bodies in order to ensure that their curricula are compliant or consistent with the national guideline. We've developed an e-learning programme that is available on HSE land, and we're pushing to make that e-learning programme mandatory for all healthcare professionals in the acute sector who look after patients with sepsis. We've hosted 3 sepsis summits, the purpose of which, the first one, was to inform senior managers about sepsis, about our sepsis guideline, and asking them to go back to their local hospital to set up a local hospital committee in order to support the implementation of the guideline within their hospital, because each hospital operates somewhat differently. We've held a number of sepsis conferences and workshops in order to improve education and awareness. We've performed audit and fed back those audit results to the sepsis committees of the hospitals, to the hospital group leaderships, and now we're publishing our outcomes. And we have measured the burden of sepsis and the effect of the changes that are implemented. And as I mentioned, this is the first of those reports. The data set that we used, well, we were given the remit that we had to be cost neutral. And there exists, of course, the hospital inpatient inquiry system, a very rich data source that is based on discharge diagnosis in hospital patients. And we use this data set, which is based on what is documented by doctors in the hospitals or in the patient's case notes on what has been the cause of the patient's admission, the complications that they have arisen during the admission, and the treatment that they have received. So we've used this data set as our measurement tool. Thus, the results that we're presenting this morning are sepsis associated, because we cannot infer causality from HIPE data. We can only say that it is associated with their hospitalization. 26% of patients had a sepsis as a principal diagnosis. And as I mentioned earlier, the international literature says that 70 to 80% of patients with sepsis have it coming in through the front door. So this likely represents an undercoding of sepsis, and I have some more data to support that view, which I'll present a little later. The overall crude mortality, hospital mortality rate for sepsis in the adult inpatient in Ireland is 22.7%. Of that, 20% of the patients were surgical, and their crude mortality rate, hospital mortality rate, was 26%. Sepsis is increasing in incidence, and this has been published in many of the international publications on sepsis also. And one of the throwbacks that can be given is that this increase is a factitious one due to an improved awareness. But I'd like to point out that our programme started in 2014 with the publication of the guideline in November of that year. And our implementation within the hospital system didn't really start to kick off until the end of 2015, the beginning of 2016. And as you can see from the slope of the curve, that it's likely that this is not the case yet. I anticipate that we'll have a big jump in the number of cases in our 2016 data set. So what are the causes of this increase of 37% increase over the last 5 years? Well, sepsis is largely an age-related problem. And currently, our population, 11% of our population is over 65 years of age. By 2041, it's anticipated that a quarter of our population will be over 65 years of age. And while this increase in sepsis cases has been contributed to by all age groups, the biggest group that has had an increase in incidence is between 65 and 84 years of age. So we can anticipate and therefore need to plan for a significant increase in the number of cases of sepsis, and we need to start to prepare for that now. And one of the ways we can prepare for that is by providing early recognition and early treatment, which is proven to reduce length of stay and reduce mortality rates. There's a small increase in mortality in the very young due to the underdevelopment as yet of the immune system, but largely mortality increases with age. Although men are more likely to get sepsis than women, the mortality difference is not present. However, there's a very strong relationship with comorbidities, and this goes along with our aging population. Not only is our average age of our population increasing, but our life expectancy is increasing, and our comorbidity burden accumulates as we get older. And with that, our risk of getting sepsis and our risk of dying from sepsis increases. We're also able to demonstrate that there's a seasonal variation in mortality due to sepsis, with an increased mortality rate in the winter months. And this is not surprising. One of the biggest sites of infection that leads to sepsis is the respiratory tract. We all know that there's an increase in respiratory tract infections during the winter months, and that disproportionately the elderly and the vulnerable are affected. Some of these mortalities can be prevented through vaccination. So we can very clearly identify our patient cohort that will benefit personally, individually from vaccination. The older patient and the patient with comorbidities, recommending flu vaccination and pneumococcal vaccination. But of course, other preventative measures are important. Hand hygiene to prevent the transmission of infectious diseases and transmittable diseases within the healthcare sector, but also within the community. Over the past 5 years, there's been a 15% decrease in hospital mortality from sepsis. And this is due to the overall improved care in sepsis recognition and management provided by frontline staff in our very busy and overcrowded hospital system. We've done a system process control analysis on this data, and it would appear that this is a true decrease, but we will be continuing to collect our data sets. There's been a 9% decrease in critical care patient hospital mortality. Now, one of the difficulties in looking at our mortality rates within the critical care system is over that 5-year period, we've had a 37% increase in the number of cases, but we've had a parallel decrease in our critical care capacity. So that means our acuity for patients admitted to the critical care area with sepsis has increased. So to achieve any mortality difference over the past 5 years is a pretty impressive achievement. And there's also been a decrease in the length of stay. Between infection and sepsis, 48% of hospital beds, patients in hospital beds in 2015, 48% were occupied with patients with either an infection or sepsis diagnosis. So it's a huge part of the work we do. This increase in cases and increase in occupancy has been partially offset by a 13.6% decrease in the average length of stay. So as I mentioned, 48%. In patients who are admitted to a critical care area with a diagnosis of sepsis, the mortality rate is 33.4%. Now, it's very difficult to benchmark our results internationally because our data sets are so different. The Australians, who would be considered to have the best sepsis outcomes in the world, have a voluntary sepsis database of ICU patients. So there's going to be an inbuilt bias in there where higher performing units are going to contribute to the data set. One of the biggest advantages of using our administrative data set is that we collect all of our data, if you like, warts and all, and it presents a very real picture of what's happening in the Irish healthcare system. The cases increase by age group, with the biggest contributor being between 68 and 84 years of age. And the mortality rate, as I mentioned, increased with age. But I'd like to bring to your attention the age group between 45 and 64 years because it's very personally of interest to me. Now, a person within that age group, most of whom are contributing to society in a very high functioning way and are very important for the ongoing function of our society, has a 15% mortality with sepsis. Now that compares to the person who's admitted to an Irish hospital with an acute myocardial infarction who has a 6.4% mortality risk. And the reason that the cardiologists have been so effective in decreasing their mortality rates by 40% over the last 10 years is because they've had a culture change. The time is muscle, is inbuilt into everybody, and we need to have the very same response when a patient presents with sepsis. The time is mortality. The critical care admission age group also mirrors the general hospital admission age group. So it's not that we are populating our intensive care units with patients with no hope of survival. Indeed, even in the older age group that are admitted, greater than 85 years, who are admitted to critical care with a diagnosis of sepsis, more than 50% survive hospital discharge. I'm also very happy to say that in Ireland, if you are admitted to a critical care unit or critical care area in any hospital in the state, your mortality outcome is the same as in any other centre within the state. So this system process control chart demonstrates that all of the hospital sites lie within the control limits. That means that any variation within these hospital sites is due to statistical variance and not due to any external effect, such as poor care or great care. So this is a great patient safety indicator that our critical care units are all performing well. Sepsis consists of 2.1% of the total number of patients admitted to the acute hospital sector, but it contributes to 18.8% of the mortality. I don't think we can overemphasize the importance of the management guideline. So part of our audit was that we looked at how are our hospitals doing with implementing the guideline. Are our recommendations within the guideline useful? Are they actually being helpful? Are they adding to the burden of an already overstretched workforce? For our population to study, we took patients with a suspicion of infection. How did we grab these patients? Well, we said, look, if somebody did a blood culture on a patient, they were suspecting infection. Now, I accept that this is already an enriched patient population because having a blood culture done before getting antimicrobial therapy is a marker of good care. So we're looking at a reasonably enriched population. And we screened them for accuracy of diagnosis and documentation, whether a screening form, a sepsis screening form was used. And this is the clinical decision support tool that we provide, and we're promoting its rollout within the acute hospital sector to aid in sepsis diagnosis and treatment. We also looked at the time to first dose antimicrobials and whether using the form was of use or not. And we've been feeding back these audits. We did 3 cycles of audit in all acute hospitals around the state. And we fed back the results to the local hospital sepsis committee, to the hospital groups, and also to the clinicians and the wards that were audited. And the purpose of these was not to compare one hospital against another or one hospital group against another hospital group. The purpose of these audits is to inform the clinicians of what's actually happening within their department. Because one of the barriers to change is a perception-reality gap. If we think we're doing great, we're not going to change. So we need to have some measurement to see how we're doing so that we know what we need to change. So in total, 1,489 charts were audited by the sepsis ADONs around the country. And the findings were, well, first of all, only in 56% of cases when patients fulfilled the criteria for sepsis was it documented as sepsis in the chart. So the 8,888 cases of sepsis that were documented in 2015 represent an underestimation by 50% of our incidence of sepsis. But if the form was used, 87% of the time, the diagnosis was correctly made. So there was the appropriate recognition of severity of illness, as opposed to 44% without the form. If the form was used, the risk stratification was more likely to be correct. So that's whether it was sepsis, severe sepsis, and septic shock. Now, if you don't recognize the severity of illness, you can't escalate the patient appropriately. And finally, we can demonstrate that it impacted on patient care. The patients were more likely to get their first dose antimicrobial therapy in a timely fashion with the form than without. We, along with our work in the acute hospital sector, we're striving to achieve an integrated approach to sepsis across the whole spectrum of healthcare provision in Ireland. We've introduced a paramedic pathway for sepsis, and we're working closely with our primary care programme, the neonatal programme, the paediatric programme, and the maternity programmes to develop appropriate screening forms for those patient groups. And the idea is that a common language and communication methodology and a common approach to treatment will be taken, so there will be seamless communication and treatment from the community into the hospital and then back into the community again. Just to give you an example of one of our pilots, our maternity screening form was put together and then we performed a pilot. 12 of the 19 maternity units in the country participated in this pilot, and just for a brief register, green is good. So if they liked it, you got the colour green. So we asked some quantitative questions. So did you like the overall layout of the pathway? Did you like different sections? And we collated the results from that. But we also asked some qualitative questions, so free text, to give people the opportunity to bring up issues that maybe hasn't occurred to us, because I'm not a obstetrician or midwife. We're very fortunate that this particular pilot was led by Karen Cliff, sepsis ADON, and also midwife. And having collated the results of the pilot, which was reviewed by a multidisciplinary committee consisting of microbiologists, anaesthetists, obstetricians, and the sepsis programme, we have developed our maternity sepsis form, which will be going for ratification early next year. We've incorporated the communication tool for collating appropriate information to try and identify the group of patients who need treatment, and also our sepsis screening form to support the doctor making the diagnosis and treatment. And I'd like to point out the complexity of these forms. Sepsis is not easy to diagnose and treat. If it was, we wouldn't require a programme. And the purpose of these screening forms is to help support doctors in making the diagnosis and treatment, not to increase their burden of work. Going into 2017, we'll continue to support the implementation. There's a scheduled, we update our guidelines every 3 years, so we have a scheduled update next year. We're very keen to develop our outcome analysis model, in particular to develop an Irish sepsis mortality prediction model and score, which would be a really useful patient safety indicator for the acute hospital sector and would allow us to benchmark internationally. And as I mentioned, our e-learning programme is now available on HSE land. I'd like to thank our Sepsis Audit Subcommittee, in particular Ms. Gráinne Cosgrove, the Senior Statistician for the Measurement of Improvement for Improvement team. Without Gráinne's work, there's no doubt this report would not be here today. And finally, I'd like to thank all of the members of the sepsis team, 3 of whom ran the Dublin City Marathon, and they accompanied with her Julianne in the centre, who's one of our patient advocates and herself a survivor of sepsis, and all 4 successfully completed the marathon. So well done, guys. Thank you.